What's going on, everybody? It's PJ here with the CRNA Drip, and today I want to talk about a couple of tips to help you build confidence as an ICU nurse. So let's get into it. Having confidence as an ICU nurse is not only necessary to be a very competent and confident ICU nurse, but also it lays down the foundation to be a successful CRNA. My first piece of advice for new grads or nurses who are transitioning into the ICU from different units is to develop a good S-bar, because nothing says or shows that you're confident than communicating effectively, communicating appropriately with the physicians or other nurses, or even patients and patient families. So I'm just gonna give an example, and this is something I'm really coming up off the top of my head when you're talking to, let's say, a doctor, for example. So let's see. Hey, Dr. Pickle, do you happen to have patient Bob the Builder in room 73? Okay, well, so I noticed when I came on shift today at 7, we were at 15 mics per minute Alevo fed, and over the course of the last 4 hours, I believe, I've been up titrating, and now I'm up to 20 mics per minute, and pressure is still dropping. You know, we started out with maps in the high 60s, and now we're in the mid to high 50s on the maps. He's increasingly tachycardic now. We started at about 103 to 105, and now we're up into the 110s range. And it looks like he may have got 2 liters of fluids earlier. I don't see much of a change in the chart with his pressure, so I don't think that he needs any more fluids. Plus, he's already, his EF is already 15%, so we might want to be cautious about how much fluids we give him. So do you want to maybe add on a second agent like vasopressin and start it at 0.04 and then see how that works? And then also we can maybe draw another SCVO2, because the last one was drawn earlier today and it was at about 78%, I believe. Okay, cool. Okay, so I'll get that started and then I'll let you know how it works out. What's your pager number again? Okay. And you're on call all night, right? Okay. All right, sounds good. Thank you. Boom. Now, I just made that off the top of my head. I don't know who Dr. Pickle is. I don't know who Patient Bob the Builder is. I don't even know where room 78 is. But providers will give you the level of respect that shows they trust in your nursing skills when you convey messages to them that shows that you're making direct observations, your brain is moving, you're making recommendations, so that you're not just presenting a problem to them and expecting them to solve it by themselves. My next piece of advice is to speak in we. Now, what I mean by that is when you are coming up with solutions to problems, or you're presenting a problem to other nurses, your manager, the doctors, speak in we. So what should we do? I think we should do this. And do you think we would get better results if we did X, Y, and Z? So when you speak in we, it fosters a sense of unity, it fosters a sense of inclusivity, and it eliminates putting the pressure on one person to come up with all the solutions to a problem, because it is the ICU, so it's very stressful, and one person cannot solve a patient's issues by themselves. Also, when you create a teamwork atmosphere, it makes you want to brainstorm. It makes you want to think of solutions to a problem without feeling like everything is a test. When you first start, you feel like everything is a test, and anything that you say could be scrutinized, and if it's wrong, then you're automatically shunned as not being competent. So try to foster as much of a team environment as possible, and also that's to the job of your preceptor when you first start as well, and making sure that they make you feel included in rounds. They make you feel included when you're in the patient's room and you're talking to the family members and explaining the diagnosis, or you're explaining what the doctor meant. It makes you feel more relaxed and more welcomed and more comfortable to speak freely about your thoughts and what you feel needs to be done. Next, ask questions. Ask as many questions as you need to, especially starting out. That's the best way to learn the flow of the unit, certain traits of different nurses, certain traits of different providers, and how they like to operate. And you know that Dr. Pickle, he likes rounds like this. He wants you to tell him this. Don't do all the fluff. He doesn't like that. He wants you to get straight to the point. And that kind of helps you transition more into being more included on the unit, and for people to notice you more and not just say, oh, that's the new person. We really don't want to hear what they have to say. So once you ask questions and you learn about whatever you asked, do your own research, follow up and do more investigations about normal ranges, why we do a certain treatment modality for a certain patient population. And then once you feel like you have that concept down, try to teach it again to someone, anyone. Just try to teach it, even if you have to say, hey, preceptor, so I was looking up the mechanism of action for this drug, and is it correct that it works like this, and that's why we do it for this patient? And that'll give you confirmation from your preceptor to say, that's exactly right. Or they may correct you and say, well, I know that's what research says, but we use it a little bit differently here on this unit. So you get that impromptu feedback that is kind of organic and it flows, and it's not like you just don't know anything and you're just asking blind questions, but you're looking for confirmation for the research that you did yourself, and that feels good as well. So just ask questions. That's how I learned a lot on my first unit. I would literally walk in a room, and even if I didn't really know the nurse that well, I would kind of just peek in and ask if they needed anything, and then look around to see if I would just be nosy, and then ask them a question about a drug that they had, running. So just ask as many questions as you need to. Next, highlight your strong suits. Highlight what you do best. So in my case, going into the ICU, I was coming out of the ER as a tech, so I was good with inserting Foleys, inserting IVs, doing EKGs, doing compressions. So whenever we had a hard stick on the unit, I would offer to look, to see, do you want me to look? I can try. And of course, at first they were looking like, who is this? And is he even good with IVs? He's new. And then, because it's a strong suit of mine, once I would get the IVs in, then everybody's like, oh, okay, he's really good with IVs. So then at that point on, that's what they were asking me to do. And I kind of became known for being the IV guy and not just the new grad. And then at that point, people will start pulling you into rooms when they have to emergently intubate a patient and say, hey, can you grab this? Or if it's a code going on, hey, can you do this? Can you mix this drug for me? And you'll start to make a name for yourself, and that in itself will kind of make you feel more confident, because you're like, wow, these experienced nurses that have been here for so long are asking me for my help. This is great. And it makes you feel, confident. Next, and this is very simple, be prepared, be organized, be ready for rounds when they start, be ready to present your patient, have everything on your ICU brain or your shift timeline. So if a doctor comes and asks you, hey, what time did we do that RSI? You can say, oh, well, we pushed the etomidate at this time, and then we pushed sucks at this time, and that didn't work. We ventilated for about 15 minutes before we had to call a critical airway, and then anesthesia came up and got the tube in. It's at 24, and it's a 7.5 tube. You're able to kind of rapidly spit off that information because you're organized, versus saying, let me go get my paper. Okay, oh no, this is the wrong patient. Okay, wait, give me 1 second. They're gonna look at you like, okay. So just be prepared, be organized. Next, set daily attainable goals for yourself. And I talk about this all the time. You have to continuously challenge yourself in order to get better. So for me, when I started as a new grad, one of my biggest things was I was so messy. I remember my first preceptor, God bless her heart, she was so nice. I would be opening like a new maintenance bag, and I would just throw the plastic piece down. I would pull the little blue piece off of the part that she spiked the bag and just throw it. And she was looking around like, what are you doing? And I was like, what? She was like, are you gonna throw that away? And I was like, oh, I'll get it later. And she was like, no, that's not how we do it. You gotta throw it away now. So I kind of had to shift that mentality a bit. And also I had an issue where I would always forget to unclamp my Zosyn. Like, I would always leave it clamped and think I'm starting the pump. 30 minutes goes by, bag full of Zosyn. Like, what is going on? I would forget to unclamp it. So on my way home, I would think about, okay, what did I do good today? If anything at all. And I would say, okay, well, good job, PJ. And then I would think, okay, well, what do I need to work on for tomorrow or for the next time that I go in? And that was one of my attainable goals. Make sure you unclamp all of your secondary piggybacks. Make sure. So I would, anytime I had a piggyback, I was making sure that it was unclamped. And, that kind of gave me the confidence to, over time, I didn't have to think about it as much. And, it didn't happen again. There's some people who have trouble scanning meds. They forget to scan meds all the time, especially if it's an emergency or, you're ripping and running between two rooms and both of your patients are pretty sick. You may forget to scan a med. So that could be an attainable goal when you're going home. Like, man, I forgot to scan 3 meds today. I need to make sure that I scan all of my meds or most of my meds today. And kind of keep yourself in line with, how well you do with each goal and what you need to work on. Also, don't be afraid to ask for a new preceptor. A lot of times our fears and our lack of confidence is instilled in us from, lack of good preceptorship. Like, some preceptors are not meant to be preceptors. You can be a nurse for 20, 30 years, but that doesn't mean you're a good preceptor. And I hate to say it like that, but it's true. And sometimes we feel like we're stuck with the same preceptor for 3 months or 4 months or however long your orientation is, and it makes you miserable. It makes you not confident, and you feel like you don't know anything once you're on the floor on your own. So if you are in a situation where you feel like your preceptor is not conducive to the way you learn or the way you would like to learn, you need to speak out and speak up on your behalf and advocate for yourself to get a new preceptor, because that might be the only time you have to learn what's going on the unit. And if you don't spend that time wisely, you could find yourself feeling like the ICU was not for you, when really you just didn't get a good background and foundation from your preceptor. So don't think that it's offensive to ask for a new preceptor. Sometimes the preceptors don't even want a precept, and by you saying that, you kind of relieve them from doing it. So don't be afraid to ask for a new preceptor. And it's not that you have to bash your preceptor when you go to ask for a new one. You just have to say, I don't feel like this is the best learning environment for me, or I don't feel like the way that this person precepts, I'm understanding the concepts as best as I can be. And your manager or your educator should understand that and foster a change for you to be more comfortable in the ICU. And it doesn't make you a weak nurse as well. So don't think that you failed or you're not doing as well because you have to ask for a different preceptor. And while we're on the topic of preceptors, if you get a new grad, your job is to make sure that they are comfortable becoming an ICU nurse. It's not to haze them. It's not to relive your youth as a nurse and say, well, when I was a new grad, I did this. It's not about you at all. So you need to make sure that you are being open, you're being non-confrontational, you're being non-judgmental, because this is all new for us, and we're looking to you as a leader and as a guide to help us get through this experience. So if you're a preceptor, just make sure that you're keeping up on the best way to precept, and keep in mind that the way we are taught in nursing school may not be the way that you were taught in nursing school, and that it doesn't make us less of a nurse, or it doesn't make you less of a nurse, that we have a different way of doing things. And just be willing to be relatable as possible, offer constructive criticism. We don't always want to hear what we're doing wrong. We would like to hear the good things as well. Once we start to get the hang of things and develop our own routine, you can start to ease off a bit. You still want to be kind of vigilant because at the end of the day, it is your patient, and I understand that. But you have the right, or you have the skills to gauge where we are and say, you know what, I can loosen up a bit. And we still want to be challenged. It's not to say that we're looking for an easy way out. We want to be challenged, but we want to be nurtured as well. So there's a way to challenge your preceptees and nurture them at the same time without bashing them or making them feel incompetent. So just keep that in mind as well if you are beginning to precept. So those are some of my tips on how to be more confident when you step into the ICU. If you have any comments or any other tips that may have helped you develop more confidence, put them down in the comments. I will reply. Make sure you like, comment, subscribe, turn on your post notifications. Visit me at thesrnadrip.com for resume, CV, personal statement reviews, mock interviews. I have some good hoodies on there. Make sure you go ahead and check those out. And with that being said, I'm out.